Is by Dr. Masakazu Toi, professor of breast surgery at Kyoto University Hospital. The title of the presentation is Addition of S-1 to Endocrine Therapy in the Post-Operative Adjuvant Treatment of Hormone Receptor-Positive and Human Epidermal Growth Factor Receptor 2 Negative Primary Breast Cancer, a multicenter, open-label, phase 3 randomized trial called POTENT. Dr. Toi.
Thank you very much. Very kind introduction. I'm going to talk on this trial results. Using S1, it's an oral 5FU, mainly conducted in Japan. And this is our COIs. In the background, the standard adjuvant, the chemotherapy for hormone receptor positive HER2 negative breast cancer patients contain anthracycline and taxanes. Dose escalation of these chemotherapeutic agents may not result in the significant survival advantages. The chemotherapy with oral FU is active.
Can you speak closer to the mic?
Sorry. Is okay? The chemotherapy with oral FU is active in metastatic situation. The multiple adjuvant trials had been conducted previously with oral 5FU have shown the positive signals. And we hypothesized that the adjuvant treatment with the S1 and in conjunction with the standard endocrine treatment would improve the survival outcomes of these patients. This is a S1 formulation, is a biochemical modulatory agent. The consisted of a Tegafur, it's a 5FU, and the Gimlacil, Motelacil, 1.4 and 1 it's a ratio. S1 will be orally administered twice daily for 14 consecutive days. It's a continuous oral administration and 1 week off. And the Q3 regimen repeated for 1 year time. And the dose determination for each individual was done like this. So using the creatinine, it's a renal function, and also the body surface area. Something like if the renal function is normal, and the body surface area is the 0.25, 0.1, then we can start with 100 milligram per day. This is a trial design. The simply comparing standard endocrine treatment and the S1 1 year. The eligibility criteria was the stage 1 to 3, and the node positive and node negative, and the intermediate or high risk patients were recruited to this trial. Randomization was done 1-to-1. The primary endpoint was the invasive disease-free survival. And the secondary endpoints were the OS, the disease-free survival or distant DFS, safety, and biomarker things. The stratification factors were age, 55 years old, and also the nodal status, the chemotherapy plus minus, the preoperative endocrine treatment plus minus, estrogen receptor status low or it's not low, and institutions. This is statistical, the analysis planning. The control group, the 5-year IDFS was estimated as 83%, plus S1, 87.8%. Hazard ratio was 0.7, it's a target, and alpha 0.5, they two-sided. The 5 years follow-up and 3 years enrollment, 332 events were expected from the 915 patients. So again, the key inclusion criteria, stage 1 to 3. If stage 3B, medical rejection, and the after preoperative systemic treatment, PST, is needed. And the with or without PST, and within 1 year after surgery, and within 6 months after starting the adjuvant endocrine treatment, you can start with S1. This is our risk assessment for this particular trial. The right-hand side, without the neoadjuvant systemic treatment, mainly chemotherapy. The without PST if the nodal involvement or lymphovascular invasion is positive by pathologist, it's eligible. If not, the grade 3 is eligible. Grade 2, over 2 centimeter eligible. The grade 1, over 3 centimeter eligible. But grade 2, less than 2 centimeter. Grade 1, 2 to 3 centimeter. We use the Ki-16 level index. Over 30% is eligible. If over 14%, we use the oncotype DX testing. With PST, neoadjuvant chemotherapy mainly, if node positive or the breast, the residual disease positive, I guess the non-PCR cases, it was eligible. With neoadjuvant endocrine treatment, if node positive, it's eligible. If node negative, they will use the same criteria as without PST. This is a consult diagram. The 1969 patients actually randomized. The full analysis set altogether the 1930. So equally randomized. The baseline demographic of these patients, the right-hand side plus S1, 957 patients were randomized. Age, they 51. The premenopausal, postmenopausal, 50-50. Body weight, 55 kilogram on median. And the histological grade, grade 1 is included at 10%. Grade 2, 60%. Grade 3, the 26%. Nodal positivity is roughly the 30%, the 1/3 was roughly nodal negative, 2/3 nodal positive. Ki-67 labeling index, the less than 14%, the 54%. The 14 to 30, the 31%, over 30%, the 13%. Chemotherapy neoadjuvant, the 20%. The post-operative, the adjuvant chemotherapy is 35-6%. So roughly the 55 to 56% were treated by chemotherapy in this trial. Invasive diameter, the less than 2 centimeter, 31%. The over 3 centimeter, 21%. This is our core result, the primary endpoint, the invasive disease-free survival. This trial was actually terminated early because the primary endpoint was met. And in the interim analysis, the median follow-up was 51 months. And the 155 events were identified in the control group and 101 in the S1 group. 81.6% in the control group, it's a 5-year IDFS, and the 87% in S1 group. The hazard ratio is actually 0.63, and the p-value was at the less than 0.001. Safety profile. The S1 is a chemotherapeutic agent that causes the bone marrow toxicity, such as neutrophil counts, the decreased, the 42% all grade, but grade 3, 7.5%. It's obviously the significantly different. And the platelet decrease also the significantly different in all grade, but the grade 3, 0.5%. GI toxicity is the more frequent in S1 treatment group. And the diarrhea, 32% in all grade, and 1.9% for grade 3. It's statistically significant. Obviously, hyperpigmentation is quite often in S1 group, the 50%. So as a conclusion, the oral formulation continuous treatment and metronomic types treatment with S1, 1 year adjuvant, together with the endocrine treatment would be important treatment option for estrogen receptor positive, HER2 negative, the primary breast cancer patients having intermediate and the high risk of recurrence. And the safety profile is within expected, and it's quite manageable. That's all. Thank you very much.
Thank you. This is open for questions from the floor.
Marisa Weiss, breastcancer.org. How would you suggest applying this to women today in the setting of genomic testing? And even though this is like a mini chemo, it's not really full chemo, you still don't want to expose anyone to chemo unless you have a benefit. So how do we use, let's say, Oncotype DX or to select people for such a approach?
Before starting this trial, we discussed a lot about the genetic testing, such as Oncotype DX, the recurrence score. Actually, we incorporated in the protocol, but for multiple reasons, it is not approved in Japan. So that's in the protocol, we use Oncotype, according to protocol, we use Oncotype DX in very minor population, but definitely we are very interested in using presumably we can analyze more in the future.
So I know you use a lot of S1 in Asia, and you get good effects in GI disease and all that, but from what I understand, we don't have that in the United States. So this is more to Dr. Arteaga. I mean, do you know of studies in the United States going on with this drug? So is this applicable to patients in the United States?
At this moment, I don't think so. The S1 is available, in my knowledge, in Japan, some Asian countries, and Europe, maybe.
This drug is similar to capecitabine, right, to Xeloda?
Yes, the final active compound is 5-FU.
Right.
It's essentially the same.
So, but it's not exactly the same as
It's not.
capecitabine.
So
you
modulation,
couldn't
yes,
extrapolate
exactly.
and say it would be the same result
Yes.
with capecitabine.
Yes, yes.
Not
Thank you.
100%.
Very important.
Nick Mulcahy, Medscape. What would be the treatment for this patient group in the United States, Dr. Arteaga? What would be the standard?
Well, the standard is to assess the risk of recurrence with Oncotype DX, and on that basis, make a call, make a recommendation as to whether that patient needs chemotherapy or not.
And what would the chemotherapy be, the anthracycline and taxane combination?
Well, it could be that. It could also be taxotere, Cytoxan. So I think, but not S1.
And then was it considered in the original design to compare endocrine therapy plus traditional chemotherapy versus endocrine therapy and plus S1?
That's a question for Dr. Toy.
We have got the trial, it's quite old trial, named NSAS-01. The targeting the node negative, comparing CMF and the UFT. That is a kind of the mother compound of S1. And the result was very similar. So that's according to this trial, the UFT, or presumably S1 might be better, but the UFT was the equivalent with the CMF. So this is our rough understanding about this agent. And so that we designed this trial, after the ordinarily the multi-drug chemotherapy, we compared plus minus S1. So we have two scenarios. One scenario is the treatment is ordinary chemotherapy, then followed by, or just the endocrine plus S1.
What's the message for the American clinicians coming out of this trial?
Well, I think we're all trying to optimize endocrine therapy for patients, adjuvant endocrine therapy for patients that need it. One approach is to add chemotherapy for those women with a high risk recurrence score. The other one is to, again, and this is an area where standards may change. There are a number of trials using CDK4/6 inhibitors in addition to chemotherapy, to endocrine therapy. Those trials, I think, again, have been completed. We are and we're waiting for events, and I think we may know in a few years that in these patients, the second agent to endocrine therapy is a CDK4/6 inhibitor. So clearly, endocrine therapy works in the majority of patients, but in some it's not sufficient. we need to add a second intervention. That could be chemo in some cases. It could be a CDK4/6 inhibitors if those trials pan out. This is another effort to do that, but as Dr. Choi indicated, again, because of standards of care in Japan, they were not able to use some of the methods and approaches and laboratory tests we use here, like Oncotype. Yeah. One last question.
Yeah, is there a reason to believe that the concurrent use of the anti-estrogen therapy with the chemotherapy agent may have subtracted from the chemotherapy benefit if the endocrine therapy was had an antiproliferative effect, interfering with the optimal cytotoxicity you could have had with the chemo? Maybe sequential therapy may have led to a better outcome.
Yeah, that's a very important point. They got the experimental laboratory data in terms of the combination effect of the endocrine treatment and the FU, such as the S1. And also we got some clinical data, as I said, the previous adjuvant trials, using the oral, the continuous treatment of the FU and the endocrine treatment, endocrine plus the oral FU. I would say it's a kind of metronomic type treatment. And it seems to be working, it seems to be active. The magnitude we need to study further, but it seems to be active. So that's we have the two major, the background on the combination.
Thank you very much. And I